I will start off, Sajesh.
Yes.
Okay.
Please.
Hello, everyone. Welcome to today's webinar session on MITH.AI at Home Comprehensive Oral Primary Care Management, sponsored by AMIA, the Dental Informatics Working Group. I am Dr. Priyadarshini, Research Representative of this group. Agenda of this session, a quick overview of the Dental Informatics Group, then our speaker introduction, followed by presentation and question session, then our plans for 2022. So main mission of the Dental Informatics Group is to serve as a reach out point for individuals and organizations with interest in health informatics, with the main emphasis on dental informatics. So our currently number of members we have is around 80 till date. Mostly 62% of the members are from academic institution, and some are from research institution, hospital or healthcare and industry. Most of the position held by our members are professor or director of the program, analyst or research or scientist. So let me go ahead and introduce our speaker today, Dr. Suresh Munuswamy. He's a medical doctor and scientist, designing and developing digital health and social care service platform. He did his MBBS in Chennai, MPH in Oxford, and PhD in Tokyo. He was the first Indian to be selected for Public Health Leadership Program, fully sponsored by Government of Japan. At Public Health Foundation of India, he's the Deputy Director of Technology Innovation and Coordinator of Government of India's first integrated Masters and PhD program in Health Informatics. At PHFI, Indian Institute of Public Health, Hyderabad, he's an additional professor and coordinator for Health Informatics Rapid Design Lab, which was started by Department of Science and Technology, Government of India. The lab is successfully developing artificial intelligence, augmented reality, computer vision, telemedicine, and geographical web enables health and social care services with funding from several national and international grants. Thank you, Dr. Suresh, for giving your time and joining us. So now you can share your screen and present.
Okay. Thanks a lot for the introduction. Hope I am audible.
Yes, yes.
Okay, great. Okay, just a second for me to do the screen share, please.
Yes.
I have a two-part presentation where I'll show a video. It's about 5 minutes. And then after the video, I'll also have an explanation and then presentation. And after that, we'll have a question and answer session. The video itself does not have any audio explanation, so please don't kind of leave messages on the chat box to say I'm not hearing anything. There's no audio to it. It's all for you to see and then probably think through the video itself. I hope you can see the video.
Yes, yes.
Well, thanks a lot for watching the video patiently, and watching the video without audio is always a bit of a challenge. So thanks a lot again. What you just saw was a platform that we are actually developing, and we are developing a comprehensive platform for at-home primary healthcare. And this is a fairly comprehensive platform, and broadly something that is designed not only to screen the disease, but as you see, to perform diagnostics, to deliver medicines, and to provide a comprehensive care at the patient's doorstep. So it's a simulation of what you actually saw. And the reason is fairly obvious. You see a map here, which shows the health access in US. And what it says here is the worst case or the maximum time it would probably take to visit a healthcare facility is in West North Central, which is about 15.8 minutes, or rather 16 minutes. The challenge with this so-called loss of averages is there will be a lot of places where you can visit a healthcare center in 1 or 2 minutes. But on the other side, you will have even more places where this 16 minutes would be 160 minutes, which possibly means you're looking at 1.5 hours or sometimes even 2 hours. And 2 hours, 1 hour is a life and death situation to many people. Now, it may not be a big difference between 1 minute to 5 minutes or 10 minutes, but 1 hour to 2 hours would be a serious life-threatening situation for several people. But if you go to India, we also have, I would rather say, a similar situation. The only difference is you have to multiply it possibly 10 times or 100 times. And in some cases, if you want to reach a health system, it's not 1 or 2 hours, but rather sometimes 1 or 2 days. And in both these situations, what you actually see is if the same disease was screened or identified at a very early stage, there is a good possibility that you may not have actually reached this situation. So primary care, as everybody knows, prevention is better than care, but it is not really practiced in most places because that's the way our health system has actually become. Because the more what we call advanced the disease is, the more profitable it is for the system. So primary care is actually overlooked, and more resources are going into bigger hospitals, tertiary care. But as I said, the primary care system is fairly overlooked here. And this is the area that we would want to focus on. So what we have developed here, or what you see here or seen here with this video, is a primary healthcare platform that does 3 things. Number 1 is it can provide primary healthcare at home. You have a mobility platform, you have a digital health platform, and it can also provide comprehensive care. And this is also something that is very necessary when you go to a person's home and want to provide any kind of a care. So if I'd want to go to a person's home and provide only oral care, now that becomes a bit of a challenge because the cost of access, the cost of me going to that particular home, to that particular individual would possibly be more than the cost of the service that I provide. So in most cases, I would necessarily have to provide comprehensive care, meaning if I go to a person's home, I'll have to provide some kind of care that is appropriate for all the residents of the house, whether it is a child or whether it is an adult male or an elderly female. So everybody across need to be provided. And it is not only holistic, but rather it is actually a way to sustain my service itself, because now I'm providing multiple cares, meaning multiple billing points and possibly multiple ways that I can actually sustain the service. So comprehensive care is necessary. And the third part is real-time service. Most of present primary care is survey driven. I go to a person's home, collect a lot of data, come back, and then by the time I actually provide the care, it becomes really challenging. And this is where our platform is actually enabled with artificial intelligence, which can provide real-time care. And it's a platform as in it has got several modules in it. As I mentioned, there are 2 major modules, or rather 2 major sub-platforms itself. And when I'm saying we'll provide primary care at a person's home, the obvious thing is we need to bring in a lot more efficient mobility platform into this. So that's one obvious part, as you saw here, the drones, the 2-wheeler platforms. But on the front end side, we have developed a very unique software which does not have any language in it. So if you go to a person's home, language is a barrier or a issue by itself, because in most countries there are multiple languages that are being spoken, and India is one country with 30 official languages. America perhaps is not so complicated, but again you have multiple languages being spoken, especially in rural areas, remote areas. And in primary care, language is a big mediator, because you'll have to ask a few questions to understand or know the signs and symptoms. So we have taken language out of the equation in our softwares. We have built an entire new software with only icons. So you need to see the icons, hit the plus or minus button, and the software will be able to come out with a differential diagnosis. But even here, to ask several questions, it is time consuming. So what we did was we are bringing out a newer version, which actually takes images and you'll be able to identify the features with images. So this is where we are using machine learning, artificial intelligence to identify the features in the images itself. With the mobility platform, as you saw here, there is a two-wheeler which has multiple temperature control boxes. And one of the unique features of medical service is that you have a lot of pharmaceutical products that need to be maintained at different temperatures. So we have 8 different chambers where you can maintain different products in different temperatures. And the same boxes, as in a cross-platform mode, can be kept on to the drones also. So wherever the two-wheelers cannot go or wherever it is difficult to access, the drones can still be sent where the icon-based software can do the screening and the interventions or the products can be delivered by the drones. Or wherever the two-wheelers can work, the drones can still act as a long-range supply chain platform wherein if you want to bring in some medicines that are only required by some people, even then these medicines can be brought on fairly quickly by the drones. So it is fairly a complete primary care platform by in itself. And this screen basically describes how this whole platform looks like in one screen. So on the left side, you see our software. It does not have much text in it. In fact, like the only text you might actually find is probably the numbers. Still difficult to convert them into icons, but numbers are still retained. And the bottom part where you see, you take the photo of an image of a feature, and then you'll be able to grade it. And then on the right side, we have built in intelligence into the platform, wherein we can bring in the responses also in real time. And the first level of response that we have built in is the health promotion messages, meaning at a very early stage of a disease, it's usually not giving a patient a tablet or an injection, but rather telling people what to do and what not to do. So we have built 30-second video clips, again without language, which identifies the products that are required, the process that need to be done, and telling people what to do and what not to do. The second step is either giving them prophylactic medicines or perhaps collecting any samples to do further diagnostics. And then the final step is basically referring them to the appropriate facility if you cannot treat them at home. And as I mentioned, our platform is fairly very comprehensive, meaning we are not only looking at the disease, but rather at the ability or the disability of the person, because in most cases, whatever intervention that you are going to provide is being used by the person, or the person will be able to adapt to it only if he is able. So we need to understand the ability or the disability of the person. Nutrition is always a determinant of almost several health conditions. And if we do not address the nutrition, it is basically not providing full treatment to the person. So we are also screening for nutrition. The immediate environment around the person is always a critical determinant for several communicable diseases, several infections. And water, sanitation, hygiene is a very critical mediator for most healthcare conditions. And this is where we are also screening for water, sanitation, and hygiene. And along with it, the socio-demographics and the economics, where the person lives, what is his immediate surrounding, what is his wealth status, because these are all play a critical role in whatever interventions we are going to suggest to the person. So we are actually screening fairly very comprehensively, but we are doing it fairly fast because, as I mentioned, we are not asking tons of questions. We are taking images and using AI ML to identify the features fairly quickly. And also we have reduced the number of questions, and it is using icons we are actually doing the screening. On the intervention side, as I mentioned, we are coming out with a unique risk profile for that person, for that particular condition, and also linking the person to the social benefits. A lot of countries around the world have benefits that are given to poor people who are actually living in rural communities, but most of them are not reaching the people. So we are using the data that we are collecting to identify what benefits they can receive and linking them digitally. And as I mentioned, the first step of treatment is actually telling them what to do and what not to do, which is the health promotion. The first line of treatment, again, is something that is available on our two-wheeler platform or brought in by the drones, which again will be given in real time based on the screening that we have done. And as an intermediate between first line treatment and facility referral, we are also planning to build in the telemedicine component or the telemedicine module into this platform, wherein we will be able to dispense certain medicines that require a physician's approval, or perhaps certain signs and symptoms have to be verified by the physician. So that module also is going to be built in. And finally, a lot of these conditions are dependent on poverty or the income status. So we'll also be providing livelihood guidance to the people on the field. Now, in comparison to the existing services, our platform is different in a few ways, and I would like to highlight in which way it is actually different. If you look at the line on the left side, most platforms or most services are focused on one disease or perhaps a few conditions. Our platform is focused on the entire conditions or the set of conditions that a person can actually face across several specialties, but also at the home and the immediate environment. So that way it is actually different. The second major difference is, again, most of the services or technology-based services would focus either on software or on the hardware. If it is point of care devices, then it is usually the hardware that is the focus. If it is scheduling service, then it is the software that's the focus. As you see here, we have a very complementary hardware and the software solution. Again, most of the present services are primarily delivered at the facility. The person has to come to the facility, whereas we are trying to take as much services as possible to the person's home. So the mobility platform is also built in. But what we are also proposing is to do a regular screening, regular quarterly screening, so that the care is continuous and not episodical as it is presently now, where if I have a disease, I call for help. Otherwise, there's no continuous care that is provided. So in several ways, this platform is fairly very different, and it is actually built on a base of a triple layered artificial intelligence core around which this entire service is actually modeled. So far, we have not built the entire platform, but that also means that we have built several modules, and several modules are actually being field tested in several places. So the next few slides are images that I'll quickly go through so that we'll have some time for question and answer sessions. So here you can see images of our software and also the mobile phones that we have distributed with the software, and 500,000 people are currently being screened across several states in our country and also in our neighboring country, Nepal, where you can see images of the healthcare worker who have been trained with our software go to the people's homes and do the screening at home. And on the right-hand corner, you see that videos are also being played in real time. And these are some of the clips of the videos, rather the thumbnails of the videos that we have developed. We are developing even more videos. And these are some of the locations where these trials are actually going on. So this is a slightly larger image of the two-wheeler platform that we have developed. And as you see here inside, you have several temperature control boxes, and you can actually carry diagnostics, you can carry medicines, you can carry devices. So this is actually a multiple product carrying platform. And also you see that we have an electric two-wheeler also. That's currently being developed. I think it's fairly very new. It's only 2 weeks old, but we'll be rolling out an electric two-wheeler platform also. And the drone basically carries exactly the same boxes as I mentioned, so that we'll be able to deliver the medicines that a two-wheeler can carry, or where the two-wheeler cannot go, we should be still able to deliver the medicines. Our idea is to provide universal healthcare, which basically means wherever the person resides, whichever language the person speaks, we should be able to provide some kind of a healthcare service, especially on the primary health side. So broadly, the operational model is one healthcare worker takes care of the needs of about 5,000 people or around 1,000 households, at least in India, where one household has an average of 5 persons in it. And we are actually kind of suggesting that this healthcare worker use our two-wheeler platform also, because it has all the medicines and also space for diagnostics and also devices. And the drone, as I mentioned, will act as a long-range logistics supply chain platform on the back end. And we are proposing that we will be doing regular screening, irrespective of the fact that the person is sick or not sick every quarter, because even a person who is not sick is always at risk of diseases. And we should be able to show appropriate health promotion videos to that person. With regard to the dental services that we can make it as part of the platform, some of the services that we are currently developing is the health promotion videos. We are actually developing several videos that can tell people what kind of homemade mouthwashes can be done, exercises for the jaw, and also other oral motor exercises, which can help at development stages. With regard to regular screening, these are the conditions where usually people do not come to healthcare facilities, and they simply let these conditions keep growing to a point that it is actually interfering with the daily life. And this is where regular general screening is a big part of our platform, where we'd want to even identify these conditions very early into the condition itself. And also, we would want to provide diagnostics and management for several conditions, including periodontitis, oral lesions that can potentially, if left untreated, become malignant conditions at a later stage. So these are some of the services that we can actually start delivering at home itself and on a regular basis. And once you identify these conditions, we will be able to deliver the products that are required to manage these conditions also, like mouthwashes, antibiotics, and probably even prosthesis, where you can take the impressions at the home, develop the prosthesis, and deliver it at home itself. So it's a complete platform which starts with health promotion videos, does regular screening, diagnostics and management can also be done, along with the logistics delivery support, which could also be done. But we are also going to the next step where, as I mentioned, instead of asking a lot of questions, we are looking at images. But even these images, we are building devices where you will be able to specifically use a particular wavelength of light to identify those conditions in a very specific way. So what you see here is different dental conditions where different wavelength of light is actually shown, so that a particular condition can be highlighted much more easily. And these will be guided by the software itself. So the icon-based questionnaire will be telling people what to ask questions, and if there are any positive signs that need to be identified, a particular wavelength of light will show up, and we'll be able to take images, and then it will be much easier to identify these conditions. So we are actually building the next what we call version of dedicated handheld device also to much more clearly identify the dental conditions. So as the next step, as I mentioned, we have built different modules separately, but we are planning to roll out a fairly large scale pilot with 1 million people, which can identify different conditions together. And we'll be able to fairly prove that a comprehensive at-home service, number one, is viable. It's already viable in several modules, but as a comprehensive service at home, we'll have to show that it is viable, it is practical, and it is also reasonably cost effective and also sustainable, so that it can be scaled up to a larger population. Well, thank you for listening to the presentation. I hope I did not take up too much time, and there is still some time for questions.
Yeah, thank you, Dr. Suresh, for the informative session. Now, the attendees, anybody have any questions can ask now.
Thank you, Dr. Suresh. It was an excellent insight how we can use digital technology, AI, for to make healthcare more accessible and more make it more customized for different specialty areas. I wonder, What kind of training you have for your associates, or are these very specialized, or what working with you on this forever, or especially in the remote areas, what kind of training they need?
Dr. Sajesh, thank you for the question. With regard to training, as you see, number one is we need to train these people. It is not what we call a self-learning module, or it is not something that people can learn on their own. So training is absolutely necessary. But if you compare them to existing services, the time that is required to train on these services seems to be a lot less. In fact, in some places in Bihar, out of maybe around 200 people, we have already trained and deployed our services. Almost 30 to 40 of them never have used a smartphone ever in their life. So we are able to train them as well as people who have been using the smartphone. Both these people we are able to train in about like in a day or something.
Good.
So
good.
as you see, it's a lot less time that it actually takes for them to even learn regular services. And the reason basically is the software itself is fairly intelligent enough to guide the healthcare worker. So basically it tells them what to do step by step. And in some ways it is more like McDonaldization of medicine. You follow the steps, you actually reach the end product. The subjective kind of role that a person has to play in the screening process is very limited. And also there's a lot less that the person has to kind of think through the process itself. As you see, all you need to do is like hit plus or minus. So a lot of intelligence is actually built in the software itself. So you will have to go through the process. The training was actually done in how you would have to take the images, and then because they have to be standardized. When you say, take a person, photo of a person's face, some people might do it very close. Some people might simply, stand in a room and, take it in a corner. So training is primarily to tell people how to take these images. And the second part of the training is basically understanding these icons, what these icons actually means. And people seem to be picking up those things very fast. And if you also look back at the icons, that the way that we have designed, you see that it's white icons in a gray background, and that's actually intended to reduce the distraction. Mm-hmm. So you focus only on the points that are actually shown in the icon. And if there are multiple features, then we add in a little bit of color here and there. But primarily the icons are designed in such a way that it does not distract you and helps you to remember things as quickly as you see the icon itself. And most cases, people do understand the signs and symptoms, except that they don't know the medical terms. So they seem to be relating to this, and they actually understand what these signs, and they are able to relate the signs and symptoms to the local people in the local language, or perhaps even the local dialect, and get the responses. So the time taken is fairly less. And at the moment, we are not looking at highly skilled people to do their training. In most cases, there are people who have just finished schooling, apparently. And the reason is your literacy status itself is not the deciding factor here.
Good, yeah.
So as long as you are able to understand, and as long as you are able to communicate in a local language or a dialect, I think you should be able to deliver the service.
Thank you. It's not only accessibility. I think what you demonstrated is that it's more, it can be through the training and repeated demonstrations, we can make it more effective and also more efficient. That's what I gather from this one. So from dental and also from public health perspective, I believe, as you mentioned, it can be used for dental, regular dental screenings, and also for diagnostic purpose, and also for management purpose. How you see it as a sustainability of this kind of intervention? Is it in the piloting stage, or from a public health perspective, is it a continuous service? How you deliver it? How you manage it?
Presently, we are actually proving a lot of things on the ground. The first thing that we have to show is people understand. Thankfully, people seem to understand. And then we also need to show people that these things, these services are doable at home, because so far we have been delivering services at a facility. So shifting the denominator to a person's doorstep means, again, there are operational challenges here. The third step is showing that people are willing to take their images. Again, there's a lot of concerns with regard to privacy. And thankfully, people are willing because they see interventions being delivered in real time.
Yeah.
So people initially were very skeptical, but now that they see interventions being delivered in real time, they are very welcoming. And we are not taking photos with personal identifiers. It's only signs and symptoms. So I think there are some challenges, but I mean, people seem to be understanding. So step by step, we are actually trying to prove, and largely this is at the moment a pilot. And as we go forward, we are actually planning to provide continuous service. At the moment, we are doing large scale screening and providing limited services to people. Depending on resource availability, we'd want to make it more like a 3-year program so that we can deliver some continuous service and show that cumulatively this actually helps people to lead a much better life. And this is where I think I would also maybe request the AMIA members to also kind of work along and see how we can actually work together, and hopefully write up some kind of a scoping paper, or perhaps a justification to say that healthcare services at home is actually viable, is perhaps like helpful to the people also. And more services could actually be delivered at home. What I have shown as a list is fairly a very small list. I think more and more services could actually be done. Yeah. And that is how I think the services themselves could turn out to be a lot more sustainable, because as I mentioned, you'll have multiple billing points, and then not just multiple billing points, but rather multiple customers within the home itself. So that way you'll be able to make the service itself viable. And one key differentiator between our service and probably every other service that is already there is that we are proposing this regular general screening quarterly to all the households. So that gives some kind of a baseline, what we call business case also. And we are hoping that health insurance companies look that data point as a very valuable point, because only looking at sick people is only looking at one side of the service. You also need to look what keeps people healthy, at what point of time slowly they start turning sick, and giving them a baseline service or perhaps a survey would be a great way to define or identify that point. And I think people would see value in this. So it's an ongoing pilot, and a lot of people have actually expressed interest in the platform that we are developing.
Excellent. Thank you. Yeah, you mentioned the digital health platform and also your mobility platform. And as you just invited the interest, I think this is something our AMIA, specifically the dental informatics group here in the US, especially our students and researchers here attending this meeting, and those members, we have a huge membership. So we can look into and make, as you mentioned, maybe a concept paper in different aspects of what you are doing in terms of comprehensive and customized care, especially for the dentistry. So that's one thing that we can look into as a follow-up of this webinar. Definitely, please, whoever interested on working on some kind of a piloting or a concept paper, we can have a separate meeting. Yeah. Other questions, please?
Yeah. Hello, everyone. So this is Barka here. I'm currently pursuing Masters in Health Informatics. So it was very fascinating to know about this intervention, which helps in the care delivery. So I was just interested to know, like, when was this initiated and how was the journey so far, sir?
Well, thanks for the question. I think we'll have to look back. Maybe for another whole seminar, I guess. I mean, again, it started with me when I was doing my master's, actually. I did my master's in Oxford. And before that, I was running a charity clinic. So that's when I realized that primary care is actually very important. And a lot of people repeatedly kept coming to my clinic simply for no reason of this. It's just the environment that they are living in is actually causing most of the problems. In masters, my topic was the role of food as medicine in tuberculosis, but apparently the father of TB in America, I'm very poor in remembering names, but there is a building named after him in Hopkins. He said, for any intervention in public health to be sustainable, there has to be a monetization platform. Otherwise, it's going to be very challenging. So this is where I shifted my topic to digitization in primary healthcare, because at least digital companies, as you see, they are the biggest companies in the world today. They have replaced oil and gas, and they are the biggest, trillion-dollar companies. Apparently, digital platforms services are monetizable, but only at scale. And this is where we identified that this regular screening has to be brought in. Even people who do not have a disease has to be accommodated because they are at risk. So we need to cover the entire population. That's what all digital companies actually are doing. And that was the starting point of our journey sometime in 2008-9, where I was doing my PhD. And thankfully, or probably very luckily, when I finished my PhD, Public Health Foundation of India was actually starting up technology-based healthcare programs. And that's where we started Health Informatics program, for lack of a better name at that point in time, and perhaps even now. India's first master's PhD program in health informatics in 2013. And we also started a lab. I think I probably loop that back to Ms. Priya's introduction, or as I mentioned, it will go on for another half an hour lecture on what we did in the last maybe 10 years now. So, well, it's been a long journey, to put it very shortly.
Thank you for addressing it.
Yeah, hello everyone. Thank you, Dr. Suresh, for this, innovative and fascinating story and journey of this. This is really inspiring. So I have a quick question on how is the journey about the partnering with any would you be able to tell me something about the partnering aspects of this particular innovation? Because I've read some articles where there are other medicine drone deliveries happening and all that. So just curious if there is something that you're partnering at the minute or anything on that aspect.
Thank you for the question. So if you look at our platform fairly very closely, you will also see that although we say it is innovative, there's actually no part of it which is not already there. So all of them are based on mature technologies. In fact, if you open up any mobile phone, although we are so-called learned and we are very literate, we all depend on icons. So it's already there. All these apps have icons in front of them. We navigate subconsciously with these icons only, not necessarily some things that we read. If you look at image recognition, facial recognition, anybody having an account on Facebook, as soon as you upload an image, automatically it highlights people's faces and then their names. So all these technologies are already there, and that also includes your two-wheelers. We did not invent the two-wheelers, nor the temperature control boxes, and or the drones also. But the way that we are actually positioning them is by bringing them all together in a fairly unique way that addresses the need on the ground in a fairly comprehensive way. So that's the innovation that we are proposing. And in fact, that's one of the reasons why at least we are not worrying if this will work or not, because these are things that already work. It's not working for primary healthcare. That's the only challenge here. But that itself is a very big challenge, because primary healthcare is not one service. It's actually a combination of about 1,000 microservices. And they all do not live in one huge apartment complex sort of a thing or in one huge community, but rather spread around all through the world. They speak thousands of languages. So these are basically the operational challenges These are the challenges that we are trying to address using technologies that are already there, fairly mature technologies. And this way, our focus has been on how to identify the need, identify the mature technology, try to bring them together so that as much as possible on our platform, we are able to deliver the service. Now, this is also where we need to understand that we don't have the bandwidth to either develop these technologies nor even develop them for the purpose that we are actually working on. So we outsource these technologies and build them, but based on the specifications that we have developed. And the moment these are built, we still need to make sure that these technologies serve our purpose. So validation is again something that we have to do. And we understand how things actually work in primary healthcare. So a lot of these things we do, but a lot of these things also are outsourced. And you'll see that almost each and every technology that you would see in our platform is actually working somewhere. But they also have the same challenges. A guy who is flying the drones is wondering, where am I flying the drones? I can't make a business case of flying a drone with 2 units of blood. It's not possible. I can't actually make a business case of flying maybe 1,000 doses of vaccines, because vaccines, thankfully, are one of the cheapest products on the world. I mean, if you excuse the COVID part, generally vaccines are fairly very cheap. So this is where we are trying to bring existing technologies in such a way that it is actually sustainable. So if I link one drone to 5 two-wheeler platforms and each two-wheeler platform to 5,000 people, even the fact that I'm actually regularly screening them, regularly providing them with the vaccine, regularly providing them with iron and folic acid tablet to at least half the population who are anemic within this 5,000, means that I'm actually engaging all 3 parts of the supply chain in a way that it actually complements each other, but also is building a business case at every level. So that's the innovation that we are actually proposing here. And that's also the reason why fairly we are confident that it will all work. I mean, taking it to the right place is the challenge, not the technology itself. In some ways, bringing all these different softwares and different products together is a challenge in itself, but thankfully that's a lesser challenge to address too.
Thank you so much, sir.
So this is Shripriya. Can I ask a quick question?
Yes, please, Priya.
Okay.
Yes.
Please.
So thank you, Dr. Suresh. The webinar was great. Though I've looked into your website, actually listening to your talk, gives more clarity. So one question I had was, how do you kind of keep track of whom you have offered services to, right? So for all the individuals, and if you collect blood, how do you kind of, is it connected to some kind of government identification scheme, or do you guys keep your own massive tracking or?
Okay, thanks a lot for the question, Dr. Sripriya. I think, as they say, a picture is worth 1,000 words, but you still need a good speech to back it up. So I think 1,000 words plus a speech is necessary. Now, with regard to the tracking, unfortunately, we are actually collecting a lot of data, and not just data, but also the type of data that we are collecting is a bit of a challenge, because we are collecting images. It's not like zeros and ones, which in some ways is a very small data set. Even if you ask 1,000 questions, if it's zeros and ones, on the data side, it will be maybe, let's say 50 KB or something. But if you're collecting 50 images, then it's going to be 50 multiplied by at least 3 MB, it's 150 MB per household. Even pushing this through a very resource constrained mobile network is going to be a challenge. It is actually a challenge to us. And then you add in different layers with regard to the encryption and the compression algorithms, and also the patient identifiers, and also identifiers for different data points, which all need to be networked. So it's fairly a complicated challenge, and then interfacing this with the government existing systems. So that's a whole rather fairly even more complicated set of challenge. Now, we have not done all these things. We are still in pilot stage. Now, what we are doing is we are pulling in this huge data sets, image data sets. We are geotagging each and every photo. We are time stamping, date stamping. And very soon we'll be also using facial recognition, because that's much easier to pull back or identifying the patient registries rather than even looking at the patient ID itself. And also we are using geotagging to pull back the house registries, because that's how we are actually linking to. Now, with regard to the two-wheeler platform and collecting the samples that are required, we are actually trying to generate a QR code which will be struck manually into the test tubes. That's how most of it is actually still done. So we try to follow existing processes as much as possible, and in some ways those are very simple. So there is not much of a need to come out with newer technologies. And linking the QR code to your patient identifier or the patient registry, and bringing back the data from the lab and then adding it up to the patient registry. So that's broadly the way that we are actually envisioning the system. Now, there are a lot of challenges, because it's kind of what we call a large data set. But the bigger challenge is in the availability of internet and the bandwidth that is available to push the data through these systems, and challenge on how much data can be held at the healthcare provider level, how much need to be pushed at the cloud level. And if you're going back and then re-examining a patient, again, you need to have how much data. Is it going to be like past 3 exams or past 10 exams? A lot of questions, unfortunately, we have not yet answered, because these are things only if we reach there, we'll be able to kind of, through trial and error, we'll be able to conclusively identify or even answer those questions. So that's the reason why we are hoping that we'll at least do a 3-year trial on a large population, because it's only at that level, by making mistakes or by kind of running through this process, we'll be able to understand the challenges and maybe come out with answers and then build them into standard operating protocols as we go forward. So a lot of questions are there that needs to be answered yet.
Thank you.
Any further queries from the participants? I think I'll request Dr. Sajesh to give the certificate of appreciation for
Sure, thank you. Dr. Suresh, it has been a great to be with you, and thanks for.
Suresh.
I hope all of you can hear. Sorry for that technical problem. So, Dr. Suresh, thank you for giving us this excellent presentation, and for this AMIA Community American Medical Informatics Association, especially Dental Informatics Working Group. This is our regular webinars. Those who are new here, we invite personalities and institutes like Dr. Suresh here, what presented today. He had given us an excellent presentation on how we can use upcoming technologies. As he mentioned, nothing is new, but the idea, the innovation here is how you can make it everything in comprehensive and customized for the needs we needed. He's using, artificial intelligence, drones and two-wheelers, facial recognition, QR codes, and tagging and everything. So. And it's scalable, and as the technology develops, we can and the data is collected and utilized and analyzed. So it makes the healthcare more accessible and also efficient and what I say, more effective. He also talked about the need of training and follow up on this kind of efforts. Excellent presentation, and I wish. Best success for you and your team and Dr. Suresh there. And we look forward to hear more from you. And this is a small certificate of appreciation from AMIA and our group. I will be sending it digitally to you. And all the participants here, I believe, Dr. Priyadarshini, that will be giving some certificate, right?
Yes.
Thank you. Thank you, Dr. Suresh, and all of you here. And on behalf of AMIA, American Medical Informatics Association, and also Dental Informatics Working Group, we invite you for our further, we have monthly meetings and other, webinars. Dr. Priyadarshini and our team, Mohammed Kader and Dr. Carmen, Sania, and they all did an excellent job for this kind of webinars and being in touch with the community. So Dr. Priyadarshini will be giving more updates on that. Thank you, Priya.
So our way forward for 2022, we have few plans under our working group. So our team is involved in developing a dental informatics curriculum, and we have monthly meeting arranged for it. And student open house discussion has been arranged on August 17th. And we are planning to write a report of status of dental informatics globally, past, present, and future. So if anybody interested in the attendees who wants to contribute their part in this, any of the above, you can just contact us. I will put up my mail ID. So every month we will have a membership meeting. First, every month, first Wednesday, we'll have a membership meeting. So for a stronger outreach, we will reach to dental schools and organizations. So certificate of attendance will be sent through all the participants through mail within 2 weeks. And the next webinar is been presented by Dr. Winnie Tan on July 21st. And the invite will be circulated as soon as possible. That's it. Thank you, Dr. Suresh, and thank you all the participants for attending today's webinar session. Hope this was very enlightening and informative. Thank you.
Thank you all. For a follow-up, please note the email here, and we can follow up with Dr. Suresh through this email, and maybe we can work on some concept plan or other projects together. Thank you.
Sounds
Thank you,
great.
Priya. Thank you, Suresh.
Thanks a lot. Bye.
Thank you. Thank you.